Well, welcome back everybody to our next session. And I am thrilled to be able to introduce Saira Salim. Saira and I have worked together for many, many years. She does a lot of work with the NHS in the smoking cessation sector. And Saira is going to be speaking to us today about vaping research and public health. This is a hugely important topic, and I'm really looking forward to Saira sharing her expertise with us today. So please welcome Saira to the stage.
Just about. If you have trouble hearing me, there are actually headphones that kind of take all this music out, so feel free to grab one of those. So I see a lot of familiar faces in the audience today, but for those who don't know me, my name is Saira Salim Sartoni. I am a health psychologist, so I'm a behavioral scientist, and I worked in the NHS Stop Smoking Services for around about 16 to 18 years with the NHS and with local government. As John said, I'm here to present some of the evidence to you today, but because I'm a clinician, I am going to sprinkle the evidence with some of my clinical insights. So this is what the next 30 minutes is going to look like, and while you have a read of this, I just want to focus us on who we are talking about. There are lots of expositions here, there are lots of products, but these products are meant for people who smoke. So I really want you to make sure that you focus on these are smokers, they are heavily addicted to tobacco, it's extremely difficult to escape from. And to illustrate this point, I just want to read you this quote from a support group on Facebook, and it is actually anonymous. I'm currently smoking my last cigarette. It's about my 40th attempt of quitting, and that usually lasts until the morning. I have a young child. I want to do better. Save those wasted dollars, be around for my family, not feel guilty and disgusting every single time. I'm nervous for the days to come, but I feel that this time I can do it. So we know that people who want to stop smoking, there's around about 60% of them who want to stop smoking. But we also know that 50% of those who are trying to stop smoking are doing this with willpower alone. They are not engaging in any kind of stop smoking medication. For people who are doing it with willpower alone, they will relate to the lyrics from the Eagles' Hotel California. You can check out anytime you like, but you can never leave. I'm not going to sing it for you, but I think you know the lyrics. So what is the impact of smoking on the UK population? So we know that smoking is the leading cause of preventable and premature death and disease. And in England, in the UK, we have around about 6.6 million smokers. So that's around about 13.3 prevalence. We also have 120 deaths associated with cigarette smoking, and if used as intended, 2 out of 3 smokers will die prematurely from smoking unless they quit. From a health inequalities perspective, 1 million people are in poverty due to tobacco use, and I'll let you into a secret, a quarter of those are children. From a health impact perspective, around about 506 hospital admissions are attributable to smoking, and with the NHS in its knees at the moment, 75,000 GP appointments could be freed up every month. That's not every year, that's every month. And in fact, our own chief medical officer stated that if smoking disappeared, the great majority of our worst cancers, they would just disappear. So there could be no greater public health achievement than achieving a smoke-free nation, and that is a feat that has the potential to save millions of lives. So in 2019, the government announced its 2030 smoke-free ambition to reduce smoking prevalence down to 5% or below. As you can see, currently the prevalence is 13.3%, and we need to get that down to 5% or below. We only have 7 years to do this, and according to the Royal College of Physicians, we will not get there until 2050. So Dr. Javed Khan was sent in, he was commissioned by the government to undertake a review to see if we would get there by 2030 and what was needed to do to actually get there. So while he was doing his review, and while he was conducting it, he asked himself a really important question. And the question was this: if cigarettes had never existed and they were invented tomorrow, what would happen? Well, the answer was simple. They would not be legislated. They would not be allowed into our shops and supermarkets. So that's quite a heavy statement, and if you think about it, it is probably true. He went on to provide 13 recommendations, and these are the 4 main ones. He asked the government to invest now 125 million per year to fund smoke-free interventions, and that's namely stop smoking services. He asked the government to increase the age of sale by 1 year every year, and he asked the government to embrace the promotion of vaping as the most effective quit tool. He also asked for prevention to be part of the NHS's DNA. And when I talk about the prevention to be part of the DNA, what I'm talking about is that any point in the NHS journey that a smoker goes through, whether he's coming in for a broken leg or a cough, if he's known to be a smoker, he will then be referred to a stop smoking service. So I've talked quite a lot about stop smoking services here, so I just want to show you what they look like in England. They were actually developed in 1999 to 2000, and they were there to reduce health inequalities and improve the health of the local communities. It's free tailored support, it's stop smoking medication, combined with behavioral support, and it's very easy to refer into. And some people are self-referred and some people get referred in by GPs or secondary care. Give me a second, I'm going to drink water. So all treatments in the NHS are evidence-based. And at the moment, if you think about what the quit rates are in the NHS, it's around about 54%. So 54% of people who are accessing the NHS, they're quitting. But I'll tell you a little secret. If you combine e-cigarettes with NRT, the quit rate rises to 67%. So that makes the chances of stopping smoking extremely successful. And this is a great lesson for countries around the world who are not yet employing tobacco harm reduction into their stop smoking services. Because people have to ask themselves, and countries have to ask themselves, if you can make this easier and more effective for a smoker, why wouldn't you? And what is going to be the impact if you don't make it easier and you don't make it successful? Well, as I've said before, I was a clinician for 16 years, and these are my conclusions. This is what I saw on the ground floor. It takes a whole lot of courage to even think about smoking, let alone come into a smoking cessation centre. And one size doesn't fit all, and I heard Aaron talking about that today. Some people did very well with NRT, some people did well with varenicline, some people hated varenicline, and some people got on very well with e-cigarettes. So one size does not fit all. But we know that I could see a significant amount of my patients didn't want to stop nicotine and they couldn't stop nicotine use. And because of that, we had a revolving door of patients coming through our clinics, because once the nicotine replacement therapy or the medication finished, they would be back out in the real world without their nicotine. And the first signs of stress from family, from job, from partner, whatever it was, triggered them, gave them cravings, and they would smoke, and then they would be back into our clinics. So it was evident that we needed a long-term, less harmful nicotine alternative. And that there prevents relapse, and that's the problem when people are trying to stop smoking. They stop smoking, and then they relapse back to smoking because they don't want to live without their nicotine, and some of them are not able to live without nicotine. So we really need to find a method that helps smokers. So one methodology that has been used in the past is harm reduction. So I'm sure you all know elements of harm reduction. I'm wishing my father used harm reduction, and I'm talking about seat belts in the back of a car. In 1973, 74, there were no seat belts in the back of a car. He put me into a carry cot. He put me in the back seat of a car. He broke one day, and guess what? Baby Syra rolled out. So I wish harm reduction like seat belts were around in the 1970s. But even if you think about the AIDS crisis, we had needle exchange schemes, and very recently, COVID-19, we have seen people wearing masks, people socially distancing. So we've seen all of that, washing their hands. These are all forms of harm reduction. So it doesn't take a genius to understand, well, if we're using harm reduction for things like AIDS and COVID-19, well, why would not use it for things like tobacco, which kills 2 out of 3 of its users if they don't quit? So it's really very simple. So tobacco harm reduction, that concept was developed by Michael Russell, who was a professor of addiction psychiatry, and he basically went on to understand from his smoking patients that they were smoking for the nicotine, but they were dying from the tar. And inherently, nicotine wasn't going to really cause that mortality and morbidity, it was the smoke. And he said the main culprit is smoke, and if nicotine could be delivered effectively and acceptably to smokers, without smoke, most, if not all, the harm from smoking could probably be avoided. But what does the science say about tobacco harm reduction? So in 2015, the UK were very lucky, actually it was England, and PHE, Public Health England, commissioned a series of evidence reviews from King's College London to gather evidence on e-cigarettes. So in 2015, they started off with that wonderful quote that e-cigarettes were 95% less harmful than smoking and could help somebody who wanted to become smoke-free. In 2018, there was a safety review, and they said it was a fraction of the risk of smoking, but it's better to switch completely away for the health benefits. In 2020, the message, obviously you can see the evolution of the message, 95% less harmful, switch completely, and if you don't smoke, don't vape. So you can see those messages coming through. The 2021 evidence review was mainly around cessation, and they found that it was the most popular stop smoking aid in the UK, and it was effective in helping people to stop smoking. And their latest and last evidence review, again, was a safety review stating that it's substantially less harmful, but it is not risk-free, especially for those who don't smoke. So two of the things that health policy makers, clinicians, and people who smoke really need to know about, 2 questions. 1, will this help me stop smoking? And 2, is it less harmful than smoking? So let's have a look at the first question. Going back to that 2021 evidence review, around about 23 studies were included in this systematic review. And they concluded that it was the most popular aid used by people trying to quit. It was positively associated with quitting, and they actually quoted from 2017, 50,000 smokers stopped with the aid of a vaping product who would have otherwise continued to smoke. So I just want to rewind a little bit for you to understand that. 50,000 smokers stopped with a vaping product who would have otherwise continued to smoke. And that, ladies and gentlemen, that is your public health benefit. But it also stated keep a wide range of choice for smokers because not one size fits all. But they did say that with that excessive, that wonderful use of vaping products, that actually vaping could have more reach and could help people more than nicotine and varenicline. At the same time that all this evidence was going on, Cochrane, which is the independent research group, they were working on a living systematic review. And this is what they concluded. There is high certainty evidence that nicotine e-cigarettes can help people to stop smoking for 6 months compared to nicotine replacement therapy. And there was moderate certainty evidence that quit rates were higher in people randomized to nicotine e-cigarettes than to non-e-cigarettes at 6 months. So I think you can all agree that the evidence for cessation is very effective. So now let's look at the evidence regarding health risks. So the government safety review by King's College London, it looked at the WHO biomarkers of priority toxicants. So that's nicotine, carbon monoxide, tobacco-specific nitrosamines, volatile organic compounds, metals, and other toxicants. And this is a top-level summary from their findings. This is from their own presentation. The report reviewed 413 studies. So when a lot of people say, we don't know much about vaping, you may not know much about vaping, and I'm talking about clinicians or public health departments, but the tobacco control community knows a lot about vaping, and it's really important to signpost in that direction. So as you can see, they looked at vaping versus smoking, which is relative risk, and they looked at vaping versus non-use. So if we look at relative risk for a minute, with regards to carcinogens, they found that exposure was significantly lower in vaping, in the vaping group. They also found the same for respiratory disease, and they found the same with cardiovascular disease, that exposure to those toxicants was significantly reduced. But with regards to vaping and non-use, they found that exposure to carcinogens was similar in both groups, but with some carcinogens, it was a little bit higher. But they found that exposure to respiratory and cardiovascular toxicants was similar between the two groups. And that led to their final conclusion that vaping poses only a small fraction of the risk of smoking in the short to medium term. But that doesn't mean that vaping is risk-free, especially for those who have never smoked. Their press release was actually quite a gift, and they stated that the levels of exposure, the levels of exposure to cancer-causing and other toxicants are drastically lower in people who vape compared to those who smoke. And helping people switch from smoking to vaping should be considered a priority if the government is going to achieve their 2030. With regard to absolute risk, Dr. Janelle de Gruchy, who is the Deputy Chief Medical Officer, stated vaping is substantially less harmful than smoking, and so it is very clear. If you smoke, it's better to vape. Let me get this quote right, sorry. If the choice is between vaping and fresh air, choose vaping. Choose fresh air. Sorry, I've messed that up completely. Vaping is substantially less harmful than smoking, so the message is clear. If the choice is between smoking and vaping, choose vaping. And if the choice is between vaping and fresh air, choose fresh air. So that conclusion is very easily understandable. So all of this evidence, plus the clinical and regulatory implications from this evidence, was summed up by a group that I'm calling the Academic Avengers. And this is Neil Benowitz, Ken Warner, Anne McNeil, and Nancy Rigotti. And they published an article in Nature this year. And they started the article with this quote: "There is abundant evidence that e-cigarettes can help some individuals to quit smoking, so they should be more widely recommended as smoking cessation aids." They concluded that we believe that governments, medical professional groups, and individual healthcare professionals in countries such as the US, Canada, and Australia should give greater consideration to the potential of e-cigarettes increasing smoking cessation. But they absolutely understood that the acceptance of the promotion of e-cigarettes as a cessation tool would likely depend on continuing efforts to reduce access and the use of products by young people who have never smoked. And they said the two objectives should coexist. We need to reduce youth access, but we need to be able to make sure that smokers have access to these products. So in England, we actually listen to our academic avengers. We listen to all the evidence. And so clinical guidelines are based on that evidence. So if vaping is found to be less harmful and it's found to be as effective as a stop smoking tool, then clinical guidance will be based on that. So on the 30th of November 2021, the National Institute of Care and Health Excellence, this is the body that looks after all our clinical guidelines, they added e-cigarettes to the list of stop smoking interventions. And just to make sure that you understand exactly what I'm saying, before, stop smoking interventions were only nicotine replacement therapy, stop smoking medications, and behavioral support. After their publication, they added e-cigarettes. So now it's e-cigarettes, nicotine replacement therapy, stop smoking medications, and behavioral support. And this is what they recommended. Ensure that nicotine-containing e-cigarettes are accessible to adults who smoke. Advise adults that a successful quit is more likely if they combine it with behavioral support. provide accurate and up-to-date information to smokers on e-cigarettes, and also advise them on how to use e-cigarettes, and include nice recommended products as options for sale in secondary care settings. Now, nicotine-containing products, according to the NICE guidelines, means nicotine-containing e-cigarettes. So what NICE are actually saying is provide nicotine-containing e-cigarettes in hospitals, in their hospital shops. That is what's happening in England, which is far, far, far away from what's happening around the world. And I think we need to be seen as an example. The government bought out their Vaping to Quit Smoking website, and the National Centre for Smoking Cessation Training bought out their guidance to help stop smoking services incorporate e-cigarettes. So that's what happened in clinical practice, but what actually happened with regards to health policy? Well, earlier in April this year, Neil O'Brien, the Public Health and Primary Care Minister, made an announcement and set out 3 aims regarding vaping and smoking. And this was part of his response to the Javed Khan review. So the first aim was help more adults to quit smoking. The second aim was to stop children and non-smokers from taking up vaping. And the third was using vaping as a quit tool for adult smokers. So with regards to the first aim, he wanted to increase access to medication, he wanted to get incentives for pregnant women to stop, and he wanted mental health settings to support, to signpost to stop smoking support. And he also stated that they were going to have a consultation for inserts in packages to promote quitting. With regards to stopping children and non-smokers from taking up vaping, he's calling for evidence to prevent youth vaping, and he's actually wanting to fund and tackle illicit vapes and the retail of vapes to youth. And finally, he announced the famous Swap to Stop scheme. And in his speech, the minister stated, and I'm quoting, so I'm looking at the screen here, vaping is already estimated to contribute to about 50 to 70,000 additional smoking quits per year in England. However, vapes are not yet being widely used enough to reach their full potential as stop-smoking aids. And in the country, we have already successfully had some pilots that have been carried out. And I am delighted to announce that we will be funding a new national Swap to Stop scheme that provide people who smoke with a vape starter kit and behavioural support. We will start by looking at 1 million smokers, and what they're trying to do is to target the most vulnerable in society first. So they're looking at people who are homeless, people who are using job centres, and people who are living in social housing. And they also state that they want to work with industry and retailers to do this. But the question that everyone should be asking themselves is, well, that's great, we've got great evidence, we've got great clinical guidance, we've got wonderful health policy, but will smokers actually use these products? And what's happening with misperception at the moment? Unfortunately, there's 30% of smokers who have never or not yet tried a vaping product. And out of those people who have not yet tried a vaping product, 20%, only 20% of them believe that vaping is less harmful. So if you do the maths, that means that 80% of people who have not yet tried a vape either don't know the difference between vaping or smoking, or think that vaping is just as bad as smoking, or if not worse, that vaping is more harmful than smoking. And this is a situation that we have to absolutely get ahead of. Now, the 2022 evidence review talked about misperceptions, and they stated that perceptions about vaping harms can actually influence vaping and smoking behavior. Communicating accurate information about the relative harms of vaping can help correct those misperceptions. So it is really important to get accurate information to smokers. And if you think about it, the accuracy of this information being communicated, maybe through mass media campaigns, could actually save a life. So in summary, we know that 2 out of 3 smokers will die prematurely from smoking unless they quit. We know that not all people want to stop nicotine or are able to stop nicotine. A smoke-free generation will only be a reality if smokers have access to products. And we know that we have a significant body of evidence now that states that it's less harmful and that it's effective as a smoke-free tool. But those misperceptions are out of line with evidence, and unless we tackle those, we can't increase e-cigarette uptake. But a balance has to be struck between preventing children and non-smokers from using e-cigarettes and making them accessible to adult smokers as a cessation tool, because the two objectives should and can coexist. Thank you very much.